please. Welcome back, everybody. Please welcome Dr. Turki Treki. He's a plastic consultant. And he's our father. He's our father, won't care.
Good morning, everybody. Thank you for the organizing committee. Thank you for invitation. Thank you for such gathering. I was deceived. They said for me they will give me 30 minutes. Then suddenly I found myself with 15 to 20. The second thing, I am not used to give one-way lecture. So I will do my best to give one-way lecture, but really I like you to participate. My talk today, really, I don't have disclosure. I did my best to delete the company names. Yet there is a product I will mention because of their mechanism of action, not because of the company. And I should mention this. It will be introduction, then assessment, then the time-bound bid preparation as an example. Very nice lectures in the beginning, from the morning until now. Yet I think the most important thing in this lecture is to do a proper assessment of the wound. So, if I ask you what is the best modality for treatment in such a wound, granulation, necrotic tissue, slough, infection sign. So, and this is the initial picture. I hope Mercy is not here, so she will not answer, okay? So, many of you, they will have different opinions. Some they will say no need for surgical debridement. You can see here there is glove, that means we are ready to do surgery. But maybe a lot of nurses, they will say, why he want to do surgery? We can make it clean with simple dressing, botulistic debridement, and so on and so forth. So this is the picture after debridement. You can see how is the wound turned to be fresh, but very big wound. With cavity, need to be packed, need regular dressing, and this is with wound care nurses, good, excellent result. So management different from one person to another, from one institution to another. And there is nothing called best management, nothing called ideal treatment. But different from one person to person, from one experience to another experience. Unfortunately, I did my I was hoping to magnify this picture. A lot of clinical cases or a lot of condition, we as healthcare provider, we don't know what to do. For example, what is the best treatment for hypergranulation? We are uncertain. Shall we involve the patient in changing of dressing at home or not? Will it improve the outcome or not? What is the best treatment for biofilm? What is biofilm itself? So a lot of question, it comes to the clinician, for example, nurse. What is the best training skill she should have in order for her to be a wound care nurse? We don't know. Shall we make the dressing standardized or no dressing to be standardized and should be different from one person to another person? Shall we make the dressing 1 week, 2 weeks the same, or we should change it every time a patient will come? So we have a lot of questions to be answered. Okay, and in this study, they try to see the clinician how much they are uncertain about their decision, for example, in regard to the wound, and in regarding to their diagnosis, assessment, okay, and if this decision related to the wound, patient, or the service. So they make decision. So what they did, they reviewed the literature, and they found, for example, they started with 20,000 and more articles. They come up, they exclude all the repetition, and after reviewing, they come up with only 162 articles. They only involve the systematic review. They exclude all others. So they come up with finally the 28 article. Out of this 28 article, only 18 article related to the uncertainty question. And out of this 18 article, they only keep the one recently added, only within the last 5 years. So the outcome is only 18, and out of this 18, they review the quality of this 18 article. They found it is not evidence-based quality of journal. So you can see how much we are uncertain as a clinician, as a nurse, as a wound care provider, as an institution. So all of this question is an area for research for us. So we can take this article, we can take this question and start working for our own research related to answer this question. Okay? So, in general, we as a clinician, we like to classify the wound into 3. Wound is the primary problem. That means I have a healthy patient who have an acute insult that cause a wound, like motor vehicle accident, like bear. Or I have a patient with secondary problem, for example, bedridden patient. So they will have a high possibility of pressure ulcer. So this wound is a sign of a problem, but it is not the primary problem. So unless I treat the primary issue, this wound will continue to be there. And then I have a patient who is in his regular life, for example, diabetic patient, who have, for example, an RTA or motor vehicle accident. Sometimes diagnosed patient, or sometime after admission, you will discover he is a diabetic, for example. So, which name is better to be called? Chronic wound, non-healing wound, or hard to heal wound? Because from the morning until now, they are telling chronic wound. For us, chronic wound is time limited. That means it is only a matter of time counted for this wound. Whereas if you look at pressure ulcer, it is very chronic wound. So what will be different if I label it chronic wound? No clinical application of this name, except for time management. Whereas if you call it non-healing wound, if it is non-healing wound, you will not have the encourage to work for it. It's not healing wound. It will give you emotionally depression, like depressant action. So usually the terminology nowadays is hard to heal wound. So we will come to this hard to heal wound. The frequency is about 1 to 2% in developed country, not in developing, in developed country. And when to call it hard to heal? If you do standard of care for at least 1 month or 4 weeks, and this wound did not improve by 40 to 50%. So now you call it hard to heal wound, and that means you need to either refer it to a wound specialist, or you need to create a multidisciplinary team to approach this wound. Okay? Now, what is the standard of care? I think most important as a clinician, appropriate assessment and diagnosis of the case. Because accordingly, you will be able to do your intervention and follow up and optimize the result. Now, what is the common hard to heal wound? We face it in our clinic. In the hospital, for example, bruchal ulcer in the ICU, for example. Or in diabetic foot in wound care nurse. Or ischemic and venous ulcer. This is the common for chronic wound. It doesn't mean there is no other, but this is the most common. And remember, please, because in hard to heal wound, there is common factor. For example, the tissue destructive agent like matrix metalloproteinase. We have the reductive oxygen species, and we have also the cell itself. For example, the fibroblast. Normally, the fibroblast will excrete the extracellular matrix, the collagen, but if it gets aged, it will reduce the collagen formation and the synthesis. But in chronic wound, it will become senescent. It behaves like an aged cell, but in a destructive way. It will produce more metalloproteinase, and it will destroy the extracellular matrix. How we score diabetic foot? I think the assessment is very important. That is why I will just mention about scoring of common wound. For example, bruchal ulcer I will not mention because, mashallah, in our hospital and other hospital, this is extensively covered. They have their own classification and scoring. Diabetic foot, we have the BDIS classification and other. I will mention them one by one. For example, this is score, which is perfusion, extent, depth of infection, and sensation score. They score or they grade the diabetic foot into 1, 2, 3, 4. If there is no peripheral arterial disease, or there is a peripheral arterial disease but no critical limb ischemia, or there is a critical limb ischemia, then what are you seeing in the extent of the ulcer, for example, intact skin or according to the size? What about the depth? Is it superficial or deep? And accordingly, you will grade it. If there is infection, is it localized or there is systemic manifestation? For sensation, they will do 10-point test with 10 gram monofilament, then they will decide. If normal sense, it will be 0, then 1, 2, 3. So the more score, the more possibility of patient to have an ulcer, the more possibility of the patient to have amputation, and the more possibility of death, according to this scoring system. I try to catch the recent score because it is very beneficial to be advanced or to be up to date. The International Working Group on Diabetic Foot, again, it's very easy, 0 to 3, from low to very high score. And according to that, there is no sensory neuropathy. There is a neuropathy, especially sensation. And there is also peripheral vascular disease in addition to the sensory loss. Or there is a foot deformity, and if there is positive ulceration in the past. So you can see low score to very high score. SINBAD, this is classification, very easy. Each segment, 0, 1, 0, 1. The maximum score is 6, and all very nice and self-explanatory. Like, for example, the site, is it in the forehead or in the mid and hind? So 0, 1. There is ischemia or no ischemia, neuropathy, and so on. So this is again very simple score. It can be adopted in any institution. Now this score, which is called Wi-Fi score, wound infection, foot score, wound ischemia, foot infection score. It has been done by the vascular surgeon, and the aim of vascular surgeon from doing this score, they want to know when to intervene for ischemic limb. So they did this study, they did this scoring before the surgery, immediately after the surgery, 1 month after surgery, 6 months after the surgery. And their target to have a free life without amputation. Amputation, a free survival, they call it. This classification to vascular surgeon, like TMN or TNM classification for oncology surgeon. So it will give them prognosis, how patient will have life free from any amputation. So they found this score very helpful in that. So the higher the score, the higher possibility of amputation. What about venous ulcer? Thank God, يعني long time I did not see venous ulcer, which is very nice. We used to see a couple of them, but nowadays no more. I don't know why. They disappear, or I don't know. Maybe our quality also improved. So this SEEP classification is very easy. This is an updated one. C for clinical manifestation, E for etiology, and then anatomical location and pathophysiology. So for C for clinical manifestation, from 0 and so on, 1, 2, 3, 4, A, B, C, D, according to what you are seeing in a clinical manifestation. For example, you are seeing varicose vein, so you will write C2. So everybody will know that this clinical manifestation means varicose vein. Etiology, either primary related to the vein or secondary, outside the vein. If it is secondary, either intravenous or extravenous. And again, you will write the letter and you will write the other letter for describing the etiology. For the anatomical location, if it is superficial, you will write AS. If it is deep, AD. And if it is perforator, AB. And if you don't know the reason, you will write AM. So, the final thing is the physiological classification, pathophysiology. Is it the cause is reflex? You will write PR, that means the pathophysiology is the reflex, or obstruction, reflex and obstruction, or unknown pathophysiology. So, by doing this, you know how to assess your or score your venous ulcer or diabetic foot. And accordingly, if you score them very well, you will know how to improve yourself. Otherwise, you will continue giving the service, but you don't know how to improve it. The other commonly used by wound care is the moist and time. Moist is used by German people or German-speaking people. I don't want to mention the company, who is always mentioning moist, but it is German related. It started at 2017 and updated in 2022. So moist stands for moisture balance, oxygen balance, infection control, and supporting strategy, and tissue management. And it has been updated 2024 also, just to give you the focus that we are only not providing the wound care, we should not forget the patient. So look to the patient in the wound, treat him, and try to prevent any other problem. Time classification or scoring or wound bed preparation is well known also by OMA. T for tissue, non-viable deficit, I for infection, moisture balance, and H. This E, when started the scoring system in 2003, it was epidermal and then changed to H. So the H is update of the initial one, and then they updated again in 2019 again, like the moist, that keep the wound, but you should look to the holistic view at the patient. So you start with the patient, identify the etiology, do your scoring, start your intervention, and check the wound. If it is healed, prevent recurrence. If not healed, look again to the patient. And when you look to the patient, you should focus on the risk factor. The risk factor is a lot, but usually the missing factor is this one, the social thing, which Arwa will talk about. That, for example, one of the aspects is psychosocial problem, for example. So if the patient is obese, you treat obesity, smoker, anemia. So you try to treat the underlying risk factor. And always remember our chronic wounds, the pressure ulcer, leg ulcer, diabetic foot ulcer, and peripheral arterial disease. Because unless you treat the underlying cause, you will not be able to treat the patient. So what is the most important for venous ulcer, for example? Compression therapy and venous intervention. You should treat the problem. Pressure ulcer, again, pressure relieving modality. For diabetic foot, unfortunately, we are always treating the patient, but we are not having any offloading system, for example. So we should really invest in the treating the underlying cause. And if it is ischemic limb, you should consult the vascular for vascular reconstruction. So this, please focus on this. This is the key point in treating such an ulcer. And if you do your best, standard of care, and this wound did not improve, that means clinically the size increased, there is a lot of exudate, there is sign of infection, there is sign of inflammation, regardless of your standard of care. That means now you need to refer the patient to the higher level of specialized people or make a multidisciplinary approach. Again, the updated, just to remind you about the time, it was time, then shifted to timers. They add regeneration and social factor. As I said, the risk factor usually, they are ignoring the patient in himself. So now the patient social support or social factor related to patient is very important. And then it was again updated to clinical decision support tools. It is tools to help you how to decide. So everybody tried to take the main scoring system and update or invest in updating the same one. This is, for example, the timers. So you can see this is the problem. Now we will assess the tissue. So I can see the tissue, there is a lot of devitalized tissue. So I will put my target is to make the wound clean. What is my modality to achieve this? Debridement, for example, and there's different modality of debridement. Same thing, I will approach the inflammation and infection. I will put my target and I will achieve it by this modality until we heal the wound. Okay, for the S, please remember, no more nowadays, we don't use patient is uncompliance. Because compliance, it contains something like, ما يسمع الكلام, he's not listening. It is only one way, like someone is ordering and the other is following. So nowadays, for example, in UK, they don't use compliance. There should be a concordance deal between the patient and the physician. And accordingly, if the patient is not concordance with the plan, you will say the patient is not adhering to the plan. So usually nowadays we are using the adherence. Patient is not adherent with the plan. All this very important because we are writing our notes. So unless we are, very careful writing our notes, also we are not protecting ourselves. Okay, especially for nurses and the physician, because the physician usually telling the nurse, please write or mention your note, but he's just doing his job and leaving. This is really not nice. So a lot of patients, a lot of doctors really saved by the good note by the nurse. So please continue your job. Okay, the time. Again, the CD, the clinical decision supporting team is like this. This is the updated time. Again, what is the tool? ABC. ABC, that means assess your patient and your wound. B, bring the multidisciplinary approach, control the risk factor, and decide about your treatment. So this is, I bring you the update from this assessment, and I think if you want, I will mention just some debridement modality, and I am done, because I will not finish if you don't stop me. Huh? So debridement, either surgical debridement by knife, by scissor. This is very nice because it is quick and you can see what you are doing and you can achieve it at the same time, either 1 session, 2 session, 3 session, according to the case. Autolytic debridement, it will take time because it depends on the patient. You have a lot of things in the market, for example, the HydroClean Plus. Again, I am not advertising, but I will tell you that they are using technology. For example, waterproof layer, polyacrylate absorbent layer. This is the blue one, and then it contains ringer, and this is non-adherent silicone coated layer. Okay, so what will happen? The ringer will go down, it emulsify and remove the debris and the bacteria. Then it will seep to the dressing and it will stay there. So when you remove the dressing, you remove everything with it. Chemical or enzymatic debridement.